Hello, everyone. My name is Cristiana Fonseca, and I would like to welcome you all to our discussion hosted by the Association of European Cancer Leads, or ECL. Our theme is cervical cancer elimination, local and European experience for global learnings. In fact, despite cervical cancer being the most preventable cancer, women all across the world are still dying from it. And that's why it's such an important theme for us to discuss. Elimination of cervical cancer cannot be achieved when inequalities remain between and within regions and countries. Communications about cervical cancer elimination requires broad stakeholders and citizens' engagement in order to assure equal access and high uptake of HPV vaccinations and high-quality screening with further diagnostic and treatment of cervical precancer and cancer. In this interactive session, we will share evidence-based solutions translated into practice, either in an European level or worldwide. The panel will focus on the issue of how to communicate in order to achieve the cervical cancer elimination goal across Europe, and how these evidence-based solutions can be used in practice when planning and conducting communication about how to reach these 1970-90 WHO elimination goals. Our discussion features 4 esteemed experts in the field of cervical cancer policies and programs across the European Union, who will focus on how to communicate in order to achieve the elimination goals across Europe, namely the 90-70-90 settled by WHO. Joining us today are Paul Blum, the HPV Vaccine Strategy Lead and the World Health Organization, who is also on the Scientific Advisory Board of the European-funded PURGE project. We are also joined by Jana Bigard of the Danish Cancer Society. Jana is also on the steering committee of ECL's Prevention and Early Detection Working Group. Inge de Kock also joins us, leading the Cervical Cancer Research Group of Erasmus MC in the Netherlands and working on another European Union-funded project, Utopia East. And finally, Raffaella Bucciardini will represent the Italian National Institute of Health, who are coordinating the PURGE project. But let's start by the beginning. I'd like to hand the floor now to our first panelist, Paul Blum, who will expand on the WHO's cervical cancer elimination strategy, as well as the impact of historical and current screening and vaccination programs. Paul, please.
Thank you very much, Christina, and really a pleasure being with you. So let me start and take some time to look at the global strategy. As you will probably be aware, in 2020, all the member states have accepted the elimination strategy. And this is really a strategy that uses an integrated approach, a comprehensive approach to addressing the public health challenge of cervical cancer. It has 3 pillars, and the first pillar is vaccination, with the target of reaching 90% of the girls fully vaccinated with HPV. The second pillar is about screening, where we need to at least reach 70% of women with high precision tests, and 90% of women in the third pillar that need to receive treatment for any identified cervical diseases. So these 3 pillars together will enable us to get an enormous reduction to 4 cases per 100,000 of cervical cancer over the next 100 years. And so we will now go into learning a bit more what the situation of these 3 pillars is across the world. And first, to look at the impact that vaccination can have. And truly, we're focusing here a little bit on the low and middle income countries. And you can see here in the curves, the different colors. The green is introducing vaccination with 90% coverage. And the modeling has shown that if we reach 90% coverage in all the countries in the world, we will be able to avert 45 million deaths in low and middle income countries. This is really the majority of all the deaths due to cervical cancer globally. But as you see moving the little arrow to the red line, which is the line where we've also added 2 lifetime screens for all women, then you can see we can not only eliminate earlier, but we can also prevent a further 14 million deaths. So in total, we can nearly prevent 60 million deaths over the next 100 years. So on the first pillar, how are we doing with the vaccination? We have made tremendous progress, and all the countries in dark green have now introduced, and these are 143 countries, nearly 2/3 of the world. But you can see these large patches of yellow where the vaccine has not been introduced yet. This is where nearly 2/3 of the population of the globe lives, so this is still the task at hand. So we're making good progress, but there's still a way to go. And let's talk a little bit about vaccination. We will hear more about in the presentations that will come, for example, from the colleague from Denmark. And you can see the different ways this vaccine is being delivered. And Europe is quite interesting. That's why I'm pointing this out because there's such a differentiation. Some countries use school-based facilities. Now, school-based is the way where with the majority of countries around the globe are using it. But in Europe, you can also see that many countries use the facility-based, because for this you need a quite strong program to invite young people to come and their parents to bring the girls and or boys. So this is more something we observe in the European countries and some other higher income or upper middle income countries particularly. So in general, what we do see is that the countries with school-based approaches have a slightly higher coverage. And so that is really, one of the learning points. Kind of going out to the girls seems to reach higher coverages. Also, a word on who are we giving this vaccine to? Traditionally, as you know, the vaccine was introduced for women, but by now, many countries, and the first to do so are the high-income countries or the upper-middle-income countries, are moving to provide this vaccination to boys as well. So the dark blue are all the countries where boys and girls have access, and the light blue is where the focus is on the girls. So increasingly number of boys and girls receive the vaccine, but WHO continues to say that the key issue, particularly in the lower middle income countries, where the vast majority of the cancer cases are in women and are cervical cancer, that the priority remains to introduce to girls in the first instance. So how are we doing in terms of coverage? Are we reaching that 90% that we need to eliminate cervical cancer? Well, from this graph, which is released actually today, we see the 2023 data. And you can see that both in the high-income countries on top, as well as the low-income countries below, there are some countries that are already reaching the 90% coverage. They have either 90 or plus or just below, but this is a small group. And below that, you have a long tail of countries where the coverage is slightly less or it's very poor. And of course, we have to think that, you can see that the average in the high-income countries is only 65% with vaccination of one dose coverage across all these countries for a vaccine that is very low. In the lower middle income country, the pattern is the same. The numbers are slightly lower. The challenges may be slightly bigger to reach these girls. So we have a long way to go, and we have to focus very much on improving coverage. In green, one of the things you can see are the countries that have started to introduce single dose schedule. These are a large number of countries, and this year we estimated that about half of the girls in the globe actually are receiving a single dose under the single dose schedule that is introduced in their country. So moving then to screening, one of the things that we see in screening is that the screening coverage is very inequitably distributed. Actually, it resembles quite a lot what we saw in the access to vaccination, where also the equity is not yet achieved. And so here we see particularly the African region and Asia, where screening now is very low. Women that receive at least one screen in their lifetime is between 0 and 10 in many countries. So there's a long way ahead to increase the access to this screening. It's not only a matter of quantity, who are we reaching when and where, but also of quality, with what type of test. And so in my introduction, I said that women should receive a screening with a high quality test. So increasingly, we try to move away from VIA and pap smear towards HPV DNA based testing. And you can see that in the countries in dark, again, the higher income countries, upper middle income countries, so the inequities here are also perpetuated, of course, start to have access to these higher high-end tests. But that there's a long way ahead for many of the countries in Africa and in Asia. But this is where the big breakthroughs will be, and then I think we will learn a bit more about this. What we particularly need is move from opportunistic programs to really organized screening. And this is a challenge not only for the countries that are starting, but even for some of the higher income countries, because not in all countries are the programs really organized and are all women being reached. So those are really some of the key challenges. And I want to come back to something that we're trying to do to improve the coverage on vaccination. And one of the things that we are starting to look at more is, what are the drivers of vaccine uptake, and particularly looking at behavioral and social drivers among the population. So we've long focused, of course, on bringing the vaccine to the people by going to the schools, etc. And we have over time maybe forgotten all we need to do in terms of building the trust in the vaccine, making sure people have confidence, working with parents, focusing very much on parents to have their intention and their motivation to get their child vaccinated, both understood and work on it. Think of the societal normative environment. So what you can see here from this framework on the right, you can see some of the constructs that we're working on that address these issues of trust, confidence, intention to get vaccinated. These will be very important to understand better. So the idea is we will have questionnaires that can be used so that we can track over time how these indicators and on these dimensions, the population, girls, parents, etc., are faring, but also health workers, so that we can intervene and develop intervention programs. So these tools will be available in some time. We're currently doing the field testing. But one of the observations we had is that probably for screening, there may be the need to have a similar approach to better understand what are the barriers, the programmatic barriers, but also the social barriers and the emotional barriers to use screening in order to improve the uptake of screening as well.
Thank you, Paul. And now moving on, we can hear from Jana Bigard, who will talk us through the importance of partnerships, stakeholders, and volunteers in the field of screening and vaccination programs and policies. So Jana, let's start.
Thank you for having me. And yes, I think when we are talking about this very important policy about eliminating cervical cancer, I think the first, for many countries, what is most difficult is actually to give trust to parents in vaccinating their children. Vaccination is a hard topic, and when you are doing this, I have learned from our experiences in Denmark that it is very, very important to be partners, to have others who you are doing it with. Also because partners can do different things. First of all, of course, you have to know how the target group, the parents in your country, what they struggle with, what are their concerns, are they mistrusting the vaccine, are they needing more information, what is the problem? But also we did ask Danish parents who would they like to have information from, and they told us they would like very much to get uniform information from trustworthy partners, and then they named them. So that was the health authorities, it was the Danish Cancer Society, and it was doctors, so the Medical Association of Doctors in Denmark. And together those three partners actually partnered up to do an information campaign. But it doesn't have to be as such an information campaign, but just to work together and to agree on the messages that you want to give to the parents can be very important, because then parents hear one voice. They do not hear three different partners, but they hear one voice, and the questions that they need to have answers for are provided. To support this partnership, it can be also very important to engage stakeholders, and that is really a field of many different partners or stakeholders. That can be nurses and doctors association, but it can also be other NGOs working with, for example, sexual diseases, or it could be pharmacies, or, I mean, only your imagination is actually making the limits. But again, it has to be relevant to parents that these stakeholders are actually supporting the partnership. But they can help you a lot when you have to answer questions.
Thank you, Jana. In fact, we are talking about the Danish reality, but the question is that all over the world, we have parents and we have children, and when it gets to vaccination, that is the real problem. The ones that are taking the children to being vaccinated are parents, and so they have to be very confident. And you are talking about something that is very crucial also, and I think, again, is something that is equal all over the world, is about the communication. And you stressed very well the idea that as many stakeholders, as many partners that we have there, all of them should say the same thing, and all of them should have the same information that is going to be spread. But my question now is, how are we going to spread this information? How do we communicate in order to have this kind of confidence that parents need? But we know that sometimes we have to communicate not on very formal settings. So how do you do it?
And again, that can be very different from one country to the others. But so again, you have to find out, first of all, where do parents in your area get information from? Is it from social media? Is it from certain partners or stakeholders? Where do they actually get the information that they need? Is the information available? Is there a website? Is there, for example, some Facebook channel or other channels where you can actually interact with somebody answering your questions? And if you do so, that needs a lot of resources. So that has to be considered from the partners and stakeholders, whether they can provide that those work hours that it needs to be in dialogue with parents. Because nowadays, a lot of people around Europe and the world are used to getting answers quickly. So they chat or they write a text message and they actually expect to get immediate answers. And that can be very difficult, but it's much easier provided if you work together. But all this it needs a communication strategy. So it needs for you to work with professionals in communications that can help you do simple messages, maybe rephrase messages so they are easier understood. It can also be that you united in Europe, for example. We work on that in ECL, trying also to say the same things in different European countries. So to talk about what to say. And I'm not saying this is easy, because it is not. You might have different understandings of the problem, and that means that you also want different messages. But the work that you put into actually speaking with one voice is really coming back to you, because the parents get ensured that these messages are the ones that you get when you ask the questions they have, and everybody is saying the same thing. So you get to speak with one voice. And that is really needed when you are confused with a million of messages coming from all kinds of sources that you might have difficulty in reading. I mean, not reading as such, but understanding who is actually giving me this message.
In fact, Jana, and you have said some words that are key words, I guess, at this moment. We should be simple. We should rephrase complex messages in simpler ones. And we should attend that our information is on one side available, but it should be also credible. So we have to wherever the mean that we choose to transmit information, we should have this kind of concerns. It should be simple to be understood. It should be available, but also credible. And this, I think, it's the worst part of the communication strategy when it gets there. But we are talking about vaccination, but I would also like to hear you about screening. Is it such difference between vaccination communication strategies and screening ones? What do you think about it?
I think it very much depends on what has been going on in the country. Are there reasons to mistrust screening? Then that can be an issue. But if not, sometimes it's more about getting through to the right women, getting to actually reach the target group. There can be, and we are going to talk more about it in this session, because some of the other people here knows a lot about this. So it's important to have good numbers to know something about your target population, who is actually participating. Do you have social inequity in who is participating? We saw, for example, or we still see in Denmark, that the young women, the women first time invited for screening, are less sure about what they're going to think about a screening offer. They may think they think, of course, they are young because they are when they're invited, but also cancer is something you get when you get older. So for them, that screening is relevant is a very, very important message. Why is it relevant, and what does it do, and how is it done? And you have to do something yourself. Maybe you have to schedule a time for your GP to get the test, or the midwife, or whoever does the screening in the different countries. But even to do that little schedule a time can be actually quite overwhelming for some women if they do not understand why this is important.
So Anna, you are a member of the steering committee of ECL, and you are also working on Danish Cancer Society. And when it gets to partnerships, to stakeholders, NGOs are a great component of this work. So how is it then either on Denmark and on ECL as much as you know?
Yeah, what we can do is actually, first of all, we can be one voice, but then the health authorities can actually make things happen, like putting information into the deliveries of vaccines for the doctors. They can actually keep up with numbers and do a lot of press releases. In the Danish Cancer Society or in other societies, we have a lot of volunteers who can actually help us communicate the messages locally, or doing local events where they talk to parents or others about vaccination and screening. And these are very important zealots that can actually sell or talk our messages in dialogues with the people that we want to reach. So these are strong tools that we can use when we work together. And then having a medical association with us, or others who have the professional skills in the area that we talk about, is again very important to make sure that the messages are correct and that we do not miss out on something. So again, these partnerships are very valuable.
So thank you, Jana. It was very interesting for us to understand the Danish reality, but now we are going to move on and we go to the Netherlands. In fact, we are going to talk with Inga de Kock. She's representing here a European funded project, Utopia East, and we are going to speak a little bit more, Inga, about that question about credibility and about how to catch a nice strategy to the communication.
Yes, thank you, Christiana, and thank you for inviting me to talk about this interesting and important topic. Indeed, as the previous speaker already mentioned, that credible information is really important in communication, but not only in communication, it's also for the design of the screening program. So I'm mainly going to talk about the screening program because there are so many flavors for screening, and this screening program needs to fit the needs in a specific country. And the only way that you can design it in a proper way that it fits the needs in a country is that you use the data that is available in a country. Because you need to think about what kind of test will I use. In general, most people believe that HPV screening is now the best test we can do for cervical cancer prevention. But it also needs to be feasible. You need to have enough laboratories. You need to have the site technicians need to be involved in this decision, because if all these people are fired, they will not be happy. And also with HPV screening, you have the much more risk that you get over screening because it's such a sensitive test, but with a bit lower specificity. So you need to have a good follow-up design as well. So what do you do when women are HPV positive? And also, how is this communicated to the women? Do they know that they need to go to the doctor? Are they not lost to follow-up? So you need to think about the test. You need to think about who am I going to invite, the starting age, but also the interval. And that depends on the risk, on the cervical cancer risk in a country. So you need to collect data to see how high is my risk and in which age groups, and how high is the HPV prevalence. So which women need this screening. And also who needs to be involved in these decisions, because if not everyone and all the stakeholders agree on the design, it's also more difficult to implement it. So in general, it's about collecting country-specific data on the country-specific risks, and also the feasibility and stakeholder opinions. I think in that sense, you can design a screening strategy that fits the country, and that will work.
Thank you, Inga. It's very important for us to understand which is the process to really get to the screening at the end of the day. And it's very important for you also. And going back to some of Jana's previously mentioned, we have to talk about partnerships, we have to talk about stakeholders, we have to talk and to think about the end users, that are the women that are going to attend and to do these kind of screenings. And we should think about the countries, as you were saying, because here, each country can be different from other, because we have different kind of needs that we should answer. And this, I think it's very important in what you have already mentioned. But to talk also about the myths that very many women have, and we have to tackle also for them to understand how it is done a screening test, who should do it. in your knowledge, is it very different from one country to the other? How do we do to tackle these kind of difficulties also?
Yeah. So, and I also want to respond to another thing, that is, I don't think it's only the women that needs to be involved, but all the stakeholders, because what we see in many countries is that a lot of opportunistic screening still takes place. And we know that opportunistic screening is in general of less quality. And then we get a lot of inequalities in countries, because there are women, a lot of women are overscreened, and a big group of women is underscreened. And only if you have organized screening, that all women are invited with the same interval and at the same ages, then we have more equal distribution, and that's better for both the individual women, but also on a population level. And there also, I think the health providers need to be taken into account, because it's also often the doctors that invite them to get their tests done. So that was about the involvement of the different stakeholders, that it's not only the women, but also the health professionals, and that they also need to understand why they need to do a certain test and when they need to do a certain test. And also about, I think a lot of women and doctors are not that aware of the harm side, and also of that overscreening. We need to try to prevent overscreening, and especially I think with the HPV test, because we can make a lot of women maybe that they feel insecure because they are HPV positive. And a lot of women are HPV positive. It's just if we need to do that not too short of an interval and too young. So and that's something we need to explain, that it's not necessary to screen at age 20 with an HPV test, and why that's not necessary.
Yes. And again, we are talking about communication and how to communicate. And we have to be very aware of the needs of the population in order to adapt and to know which kind of tools we have to use, what kind of means we have to use to have this credible and this useful information.
And I think it is different per country. I think that's also what you asked, because it does depend on how many women are vaccinated, how young are they vaccinated, and also on the level of risk, and on the whole health system that is in place. So and the number of doctors and the number of money available for screening.
Yeah. Thank you, Inga. Now to Raffaella Bucciardini, who will review some of the inequalities frequently experienced by marginalized or underserved population in acquiring cervical vaccination and in screening uptake. Thank you, Raffaella.
In 2022, according to data from the Global Cancer Observatory, cervical cancer was the 9th most common cancer among women in Europe, with an estimate of around 50,000 cervical cancer cases and around 26,000 deaths. Incidence rate vary widely across Europe, with age standardized incidence rates ranging from less than 5 cases per 100,000 women in Finland, Luxembourg, Malta, and Switzerland, to above cases 15 per 100,000 in Ukraine, Bulgaria, Latvia, Romania, and the Russian Federation. The age-standardized mortality rates is less than 2 deaths per 100,000 women in Austria, Belgium, Denmark, Luxembourg, the Netherlands, Norway, Italy, Spain, Malta, Finland, and Switzerland, and above 7 deaths per 100,000 in Ukraine, Moldova, and Romania. The disparities in vaccination and screening uptake contribute significantly to different rates of mortality and incidence of diseases such as cervical cancer. Effective screening and vaccination programs are crucial in reducing the burden of these diseases. HPV vaccination programs have been implemented in various European countries, targeting both females and more recently males. However, coverage rates vary significantly, with some countries achieving high uptake and others struggling to reach a significant portion of the population. Some countries, such as Norway and Portugal, report national coverage about 90%, while some countries, including France and Italy, report coverage below 50%, and Romania and Bulgaria report only 6% coverage. Cervical cancer screening practice also varies significantly across Europe. Some countries have a national-wide population-based program that ensure comprehensive coverage and early diagnosis. In contrast, other countries rely on opportunistic screening, which depend on individual initiative and meetings with health professionals. Inequalities in screening and vaccination uptake can be attributed to several factors, including socioeconomic status, education, healthcare accessibility, and public health infrastructure. Lower socioeconomic groups often have reduced access to both vaccination and screening services, resulting in higher disease incidence and mortality rates in this population. Besides, rural areas and less developed regions face significant challenges in implementing and maintaining effective screening and vaccination programs. Urban centers typically have better healthcare infrastructure, leading to higher adoption and better outcomes. Addressing inequalities in vaccination screening uptake is crucial for reducing the incidence and mortality of cervical cancer and other preventable diseases. A comprehensive approach should be taken in consideration by policymakers and healthcare providers, such as increase awareness and education about the importance of vaccination and screening, improve healthcare infrastructure in underserved areas to ensure all population have access to the necessary services. Develop and enforce policies that mandate equitable access to screening and vaccination programs. Continuously monitor vaccination screening programs to identify and address gaps in coverage. By taking these inequalities, we can achieve better health outcomes and reduce the overall burden of preventable diseases.
But Inga, you are here also because in Erasmus MC you have been working with this European funded project, Utopia East, and we also would like to understand how this project contributes to the issues that we are talking here. So can you explain us a little bit more about the project?
Yes, of course. So Utopia East is a follow-up project from a first EU-funded project, which was called Utopia. And within the first project, within Utopia, we developed mainly 3 different tools that can be used for policymakers, country-specific policymakers, and researchers to design the most suitable screening program in their country in the current situation. So the first tool we developed was a monitoring tool. With that tool, people in a country can collect their country-specific data, that is the most essential data, to understand how are we doing, what is the current situation, what is the current risk, and what is the HPV prevalence, what is the cancer incidence, how many women are already reached by screening, what is the under-screening rate and the over-screening rate. So there we developed a tool, the monitoring tool, to collect data for the current situation. And then we developed a second tool, which is called the evaluation tool. And in that evaluation tool, researchers and policymakers can simulate different strategies, vaccination and screening strategies, to see what will happen in their country if they would change situations. So they use the data from the monitoring tool, they put it in the evaluation tool, and then they can start simulating different situations. So what if we would switch from cytology screening to HPV screening? What if we would change our starting age? What if we would reach more women, for example, by implementation of self-testing? And then they can see what would that mean for the future incidence of cervical cancer, future mortality, but also what will it cost? And how many women will be referred with this strategy? Or how many health providers do we need? So, and then we have a third tool where they can see what kind of barriers exist in their country and take that into account. And then these 3 tools together, they are used to develop a country-specific roadmap, which is then communicated with the policymakers. And all the people in Utopia are involved. And now in Utopia East, we are implementing these roadmaps together with the local policymakers and the local stakeholders. And they are all involved in using the tools and to build capacity to be able to follow the steps of the implementation and improvement of the programs.
Thank you, Inga. Moving on to another example, the PERCH project aims to develop the national HPV communication vaccination guidelines, and it's coordinated by Raffaella at the Italian National Institute for Health. She can now run us through lessons learned from the project, including the strategies to increase vaccination rates and addressing inequalities.
On November 1st, 2022, European Partnership to Combat HPV, PERCH, was established with the aim of contributing to the implementation of the Europe's Beating Cancer Plan. Specifically, PERCH is funded by the EU4I program 2021-2027 and aims at supporting Member States' effort to extend the introduction of routine HPV vaccination of girls and boys. The partnership is coordinated by Italy and includes 18 European countries. PERCH's main specific objectives include improving the capacities of member states to plan and implement HPV vaccination campaigns, optimizing data collection and monitoring systems for HPV vaccination, increasing awareness about HPV-related diseases and prevention among adolescents, and improving communication skills of healthcare professionals regarding the HPV vaccine. To reach the specific objective, the main activities are organized into 7 work packages, which include communication dissemination, integration and sustainability, monitoring, improving knowledge and awareness, and training and support in vaccination communication. PERCH will end in April 2025. We will probably ask for a 4 months extension, and the main results are public and can be found at the following address. In the first 20 months, PERCH achieved significant results. Regarding communication dissemination, a comprehensive strategy has been developed, including websites, social media, and newsletters, to ensure the dissemination of information. The monitoring allowed the collection of comprehensive data that highlight disparities in vaccination rates, identify areas in need of improvement. The results show that while some countries have achieved high coverage rates, others still require significant improvements. A report has been produced describing the main determinants of vaccine efficiency at the national level. Finally, training programs for healthcare professionals, according to the specific national context, have been initiated to improve their communication skills and increase confidence in HPV vaccination. PERCH is laying the foundation for further action to improve vaccination coverage in Europe and reduce inequalities. This action should include improving surveillance and monitoring of HPV vaccination coverage. The availability of data on HPV vaccination, HPV screening, and cancer incidence and mortality, and the linkage between them are essential for monitoring the process and the impact of vaccination. Unfortunately, there is a huge heterogeneity between countries and within countries with respect to the availability of data, methods of collecting and monitoring. Ministries responsible for health and justice should create legal frameworks that facilitate the monitoring of health and preventive programs.
As much of this theme is of interest, and I'm sure that we would keep on talking about that, the truth is that we have to wrap up as our time is running out. But before that, I would like to thank all of the speakers. And of course, I will also thank ECL's Prevention and Early Detection Working Group, because much of the things that we are talking about here today are the things that we talk through the year in this group that is led by ECL, that has experts from NGOs and cancer leagues from all over Europe. For you that are attending the session, I was also to thank you for the trust and for accepting our challenge and to see this online. But I would also like to say to you that some of us will be on Geneva on the Congress, so please look for us and we will be keen to talk you through all these themes and much more that we do in our own organizations and of course in the projects that we are running. But if not, I wish you all a very pleasant World Cancer Congress in Geneva, and so likely someday we'll jump on each other's on the corridors or in life. So thank you so much for all of you and see you soon.